So this one's common. I think there's lots of things you can ask and test about this, and I think it's something we should know as far as how to treat, and it's also one that has a very specific antidote. So iron happens a lot, especially in pediatrics, because it's not treated like other medicines that might be locked away in the medicine cabinet or a pill box. It's treated a lot more like a food and it's left on the table. And then we have these ones, although less toxic, all the ones we give kids that are like cartoon characters, maybe dating myself here with the Flintstones vitamins, but I'm sure there's newer cartoon characters of, SpongeBob or something out there nowadays. And so kids say, "Oh, look at that, a cartoon. I'm going to eat a whole box." So that was the good news is, um, oh, someone says they still have Flintstones, so don't feel that old. Basically, they're very easy to, a kid to just eat them. They're sugary, sweet, and flavored. And the good news is most of the sugary vitamins ones are poorly absorbed, but you can reach a threshold where I guess they could be. Here's all the different ones that are out there, Bubble Bunnies, Smurf, and Scooby Doo, and whatnot. So, a little bit about the terminology. I always get confused when I use ferrous and ferric. They may put those on the boards. Food is in the ferrous state or the divalent Fe+2 state, and body iron is in the ferric or the trivalent state. And our body converts the two. And iron is poorly bioavailable. We usually eat 10 to 20 milligrams a day of iron, but only absorb 1/10 of that. It gets transferred around our body with a protein called transferrin, and some of it ends up in the bones for making blood, and some of it ends up being stored in the liver and potentially the heart, and some of it ends up in other tissues. We don't have a mechanism for losing that iron except by two ways. We bleed or lose blood, or we desquamate our skin where some of the iron is deposed. But it's only a milligram per day in versus a milligram per day out. What happens with toxicity is ferrous and the Fe+2 is absorbed across the brush border of the duodenum mostly by another transferrin, which isn't the blood transferrin. And what happens with iron salts is they wear down this outer protective membrane, this transfer protein, and you get wide open absorption. So that 1/10 absorption that is usual as long as everything's intact with your intestine is destroyed, and you have much faster and higher amounts of iron absorbed where it's converted to the Fe+3 form in the body. And then it gets transferred everywhere by transferring. Now, you don't have to get ferritin or transferrin levels or even hemosiderin levels, which are all blood tests when you look for iron labs. None of those make a difference in making a decision about who gets treated or not. We can just go for the total iron level, which includes both bound iron and free iron in the blood. And we can make some decisions who to treat after an ingestion based on that. So typically, iron levels are 50 to 150, and something called the total iron binding capacity, which used to be done almost uniformly with every iron level, is about 3 to 4 times that, so up to 400 mics per deciliter. This is all the different ways that iron can be bound up and transported in the blood, not just transferrin, but it doesn't really matter. It can go up as an acute phase reactant. So just from nausea and vomiting, your TIBC can go up 100 points or more. So it's not very useful. People used to try to do the ratio between these two things, and it just doesn't make sense. So just the iron is the important one. So here's my mnemonic, how to remember how much iron is available for each of the different formulations of iron we can take. If you have iron, you might have a fast shooting gun or a 357. And so if you have fumarate, the first letter there, you divide by 3. So 33% of that is elemental iron. And if you have sulfate, the second letter there, you divide by 5, which is 20% elemental iron. And if you have gluconate, you have 12% elemental iron. Now, there's a couple other salts that are out there, and of course, you have to look those up. But I said the vast majority of ones you'll see are gluconate, sulfate, and fumarate. Sulfate's the most likely thing that's prescribed to people. There's another form of iron, there's two other forms of iron that are generally non-toxic. The first is carbonyl, and I always to kind of tell people to rotate through our poison centers, say if you have a mother who's taking prenatal vitamins, give them carbonyl iron because if the kid or other children at home gets into carbonyl, it's poorly absorbed. Even though the 100% bioavailability for mom, it's free iron. It doesn't destroy the brush border due to its caustic effects of assault. And even in overdoses, you only absorb what your body needs. So it's completely non-toxic, and it's not really that much more expensive than other prenatal vitamins. Plus, ferrous sulfate, the traditional historical prenatal vitamin that's out there, is pretty constipating and turns your stool sort of blackish color. And, it sometimes can be fused with occult GI bleeding. So all those things are probably, in my mind, make it more important to use carbonyl iron as prenatal vitamins. So I mentioned ferrous sulfate. 325s is typically the one that's mostly prepared. If you divide that by FSG 3575, 325 divided by 5, 65 milligrams per tablet. So what does that mean for who gets sent in and who's going to get sick? Well, less than 20 milligrams per kilogram is non-toxic. If we're like, we can call them back, but they don't need to be sent to the hospital. Greater than 40, treatment may be needed, but a lot of times it's usually the worst case scenario, and I might watch those at home. Chewable vitamins are usually not particularly toxic, although when you start getting much higher than 60 or even 100 milligrams per kilogram, or the ones that develop symptoms, may need to be sent in. I think our threshold to send to the hospital, and I think that's uniform across the country and certainly potentially testable, is 60 milligrams per kilogram. And above 200 is potentially lethal. So just because you're 60 doesn't mean you're going to be in really bad shape, but if you're 3 or 4 times that, you can be. So here's the first example. A 10-kilo toddler eats 10 tablets of ferrous sulfate. They may have you do the math here. So it's 65 times 10 divided by 10 is 65 per tablet. 10 tablets is 650, divided by 10 is 65. So that's a send-in amount, right? Of 60. 10 kilotaurin gets 10 tablets of ferrous gluconate, which happens to come in 300 milligrams. 300 milligrams times 12%, remember gluconate is divided by 7, is only 36 per tablet. 10 times 36 is 360, per kilo is 36. That child can probably be watched at home with a follow-up phone call to see if they're having any symptoms. So in adult volunteers, when they had them eat chewable ferrous fumarate and tablets, they had some absorption, but very few of them, and none of them really got sick. And our experience is it's really decreased toxicity with the amount of sugar it's in the children's vitamins. So I think most of those ingestions, despite the milligram per kilogram calculations, can be watched at home. I might get nervous if the calculation comes out above 100 per kilo or certainly above 200 per kilo, because that's a lot of iron potentially waiting to be absorbed. So typically what we get is the question, I don't know how many are missing. So we often recommend a KUB. Sometimes I'll wait till they stop vomiting if they've been vomiting, because usually if they've been vomiting, they often got enough to be a problem. But if they've stopped vomiting and there's still little tablets and you can see a little cluster up there in the stomach up at the top, then they may need whole bowel irrigation to wash the remainder of the iron out. I'd try not to give these folks antiemetics. I let them vomit their toxin clear, and then I'll treat them with antiemetics and certainly with fluid hydration in the process while they're going. KUB is good if you see stuff. It doesn't mean anything whatsoever. If you don't see anything, some form of iron tablets may be less radiopaque than others. Liquid preparations and chewable vitamins tend to not be seen very well. And after a few hours, the reliability of seeing how many pills are left in the stomach is pretty inaccurate. But if you see some, I would go ahead and continue with whole bowel irrigation. So iron goes through different phases. First phase is the GI phase. It happens almost immediately. Nausea, vomiting, diarrhea, abdominal pain. The stools can get bloody or even melanotic from upper GI bleeding. Patient needs to be resuscitated during this phase. During the second part of that phase, they often have a deteriorating level of consciousness just from exhaustion of vomiting and volume depletion. And during this time, they start to have some cardiovascular effects because ferritin is rising in and of itself is a vasodilator. So contributing to the volume depletion and vasodilatation is this shocky appearance that happens in phase two. Additionally, iron can be a direct myocardial suppression. So you have sort of a triple whammy going on here. Decreased cardiac output, vasodilatory that's not really compensating for the decreased volume, and then of course decrease into vascular volume. So at the end of phase one, they're typically tachypnic, tachycardic, hypotensive. People talk about pallor and acrocyanosis, so I think those are less important. And I don't really understand why they would have local cyanosis other than shocky children have delayed capillary refill, and typically their nail beds are blue because they have poor peripheral perfusion as a result of that. At this point, they may have three what was often felt to be harbinger labs: an anion gap, hyperglycemia with a glucose above 150, and a leukocytosis, mostly due to a stress response of demargination of white cells from where they're sort of normally kind of resting in place along blood vessels. It doesn't mean there's an infection if they have a white count of 15. It just may mean the stress of adrenaline release, which can happen with a lot of processes, has released them. So if you have someone who may have eaten vitamins and they have nausea, vomiting, and anion gap, hyperglycemia, and leukocytosis, I think that's maybe enough to start treating them with the antidote, which is deferoxamine, especially if there's going to be a delay or an impossibility of obtaining a whole blood iron level. None of those markers or combinations of markers were able to predict iron levels above 300, but they're suggestive. On the flip side, the absence of all three markers had a pretty good negative predictive value, meaning if you didn't have hyperglycemia, leukocytosis, or spontaneous vomiting, the odds of you having a serious iron ingestion are pretty low. But if the milligram per kilogram calculation comes in high enough, I would still push to document with a whole blood iron level. The next thing that tends to happen, and in the old days, before we got vital signs in kids and things like that, a lot of these kids got sent home. They go, oh, good, look, they stopped vomiting now. They must be getting better. They had this resolution phase where they're a little sleepy, and people said, well, just bring it back if anything happens. And that was when kids died. We don't do that anymore. I think we take vital signs on everybody so we know that they're tachycardic or hypotensive, at least based on their normal age findings. But during this phase, bad things are starting to evolve. Lactic acidosis is occurring from tissue underperfusion. Of course, we can measure lactate very easily now, and it's a result of anaerobic metabolism. There also may be some mitochondrial damage. There may be some release of hydrogen from the conversion of the body Fe+3 to Fe+2 by some of those oxidative enzymes. There may be some bleeding that are adding to this. There may be some third spacing potentially in severe cases. But eventually, in phase three, which happens after a day, they start looking kind of like a Tylenol ingestion. They have rising liver functions, rising coagulation factors, and rising bilirubin. And at this point, any hyperglycemia that may have occurred in the early phase goes away, and they become, as they exhaust their compensatory ability for the liver to deal with sugar or make new sugar, they get hypoglycemia. Lots of other things can occur, especially in the larger overdoses and the ones that are sick. They can have GI bleeding. They can have perforation with acute peritonitis. They can develop renal failure due to hypotension or perfusion. They can get decreased cardiac output and look shocky. With that, they can back up and have acute pulmonary edema and need intubation and supportive care. And then, of course, the end result of almost everything is bad and toxic. They can have coma and seizures from really high levels, and the aggregation of all these multi-organ system failure events. If they survive all that, they can have some downstream late sequelae. Gastric scarring is reasonably common. They can develop achlorhydria, the inability to excrete hydrochloric acid in their stomachs, and therefore some digestive and absorptive problems, especially with vitamins. They get stenosis in their pylorus, they can strictures and obstruction, and they can develop hepatic injury or hepatic necrosis in the more severe cases. Again, I don't want to emphasize the TIBC because we don't use it anymore, but pretty much the chelation is based on labs drawn between 2 and 4 hours after ingestion, or as soon afterwards as they can. People who are having symptoms, nausea, vomiting is probably enough, and their iron level is above 350, they probably should get chelated because the chelating agent is not particularly toxic nor expensive, and it will bind any free iron in their system. I can't think of too many cases where the iron level is above 500 where I would hold off on chelating them. Mind you, I would probably resuscitate them first because that's important to get their volume status back to normal because it's an imperfect chelator and it works best at normal pH and normal volume. But pretty much those above 500 should be chelated. Above 1,000, they should probably get treated and transferred to a pediatric ICU because those are the ones that are going to develop all this multi-organ system failure, renal failure, potentially seizures, and need to be in a place where they can respond to all those issues. So basically, levels 6 hours or more are not very useful, but we still use them. So even though it says that. So what's the chelator we use? The chelator we use is deferrioxamine or desferrol. It's derived from a fungus. It binds free inorganic iron, but not the transferrin or ferritin-bound iron. It chelates a little bit of iron out of hemosiderin, but not enough to be clinically important. And the bound version, ferrioxamine, which is the chelated iron, is then excreted by the kidney, and ferrioxamine is pink to red in color. And we can use a test to figure out if there's free iron by giving a deferoxamine challenge dose and then carefully looking at their urine over time, because we'll see ferrioxamine if there's iron that's available to be chelated. So the chelation challenge test is you give a loading dose of deferoxamine. So not just a slow 5 milligram per kilogram starting dose, but a full 40 milligram per kilogram, either IM, which is the original description, or IV. I can't imagine any of these kids not having an IV, but if you didn't, you could give it IM. You give it over like an hour, and you look at the urine carefully, usually with a Foley in place and pulling off samples every hour or so. And if it turns vin rosé in the textbooks, then you've got free iron. Here's a picture from an old Gold Franks about the urine after a chelation challenge test. Here's where they pulled off the urine, put the test tubes in a rack so you can see how they look over time. You can see after about 2 hours, 4 hours, they get bright orangey pink and slowly resolve. I would suggest doing this and labeling them like this because just looking at the urine in isolation, it may be hard to tell if it's more or less pink than it was an hour or so ago. And this is at least a good visual clue to the fact that your chelation challenge has turned positive and there is a need to continue to chelate until it's clear. Problem with desferoxamine is it's not that great of a chelator proportionally. You can give 100 milligrams of desferol and it'll only bind about 9 milligrams and change of iron. So if you give a whole loading dose of a gram or 10 times that, you're only binding about 90 milligrams of iron. And most of these ingestions have taken much more than that. The efficiency of that binding decreases in acidosis and volume depletion. So it's probably best to do this to resuscitate them aggressively, correct their acidosis that it exists, even up to including using bicarb in the citric cases, and then using the deferoxamine before in order to get maximal efficiency out of the binding product. What about gastric decon? Iron, like all small ionically charged compounds, are not particularly well absorbed by charcoal. If there's a second compound involved, sure, you can go ahead and give charcoal, but usually charcoal doesn't work. People used to give bicarb to convert the ferrous iron to non-absorbable ferric carbonate. Yeah, it's kind of controversial how much this works, but it wasn't unheard of years ago to take an amp of crash cart bicarb, mix it with 5 parts of water, and let the child drink it, sometimes early on with Ipecac in the old days, and try to get that out of the kid's system. It probably converts some, felt to be less than 15% of the ferrous ion, but that may be enough to cause less of a body burden. It is not recommended any longer. And I guess if you got it on a test and someone said, I want to give them bicarb, either IV or orally, the answer would be no. Don't do that. But go lightly seems to be the thing that's come along in its place. Using polyethylene glycol, which is how it'll be written up in a question, sometimes referred to as whole bowel irrigation, and known as the brand names Go Lightly and Colite. This is what we use for bowel preps for people who are going to get colonoscopies or EGDs. You have to drink a lot of this. It's hard. You have to be coached to drink it spontaneously. Often the right way to do it is to put an NG tube down and give a half a liter to a liter in children an hour, up to 2 liters an hour in adults. As far as the deferoxamine dose, you can start a constant infusion. We used to start at 15. Now I think they ratcheted that down to 5, but I would be quick to turn up the rate to try to get to 45 to 50 in the first 6 to 12 hours or so. The idea is you want to bind it while it's in the serum before it redistributes. So getting the chelator on board during that pre-distribution phase is probably important. The textbooks say don't exceed 1,000 milligrams per hour and don't exceed 6 grams per day. But we've had seriously cases where we've done more than that. And we've had cases where we've gone up to 75 and 100 milligrams per kilogram per hour. You can imagine a 100-kilo person, 100 kilos per hour is like a gram per hour. And they have multiple grams per day. But, these are people who had enormously elevated levels in the thousands. Speaking of which, in the pre-deferoxamine era, how high could you go with the survival? Reported was 8,000-ish. Post-deferoxamine, double that. Deferoxamine, the side effects. ARDS has been reported with high dose and prolonged infusion and serious overdoses. So something to be looked for. They're going to be hopefully in an ICU, getting ICU care and looking at their pulmonary function. Anaphylactoid reactions can occur through histamine release with rapid infusions, which is why we start low and go slow and increase the level carefully and resuscitate with fluids and or Benadryl if need be. Sort of the question they always like to ask is what sort of bacterial problems can this unleash? Apparently, things that are siderophores that love iron, like Yersinia and Mucor, can overgrow in the gut of people treated with deferoxamine, and they can get Yersinia enterocolitica, gastroenteritis, and Mucor has been reported in a handful of small number of cases. How long do we treat? We keep going until the iron's below 350. The urine, if we're watching the color, is cleared from pink. All other clinical signs of toxicity and acidosis have resolved. So it's sort of a fuzzy endpoint, but usually most people need to be treated for 12 to 24 hours. We've had cases that have been really sick that have had 3 to 5 days of treatment. So it's based on how sick they look and how quickly they're getting better. The textbook often says you treat them for 6 to 12 hours and then you stop. And that may be an answer to a question on a test. Pregnancy, save the mom, save the baby. That's the basic rule for all toxins. Now, none of these items plus the presenter well, including iron, but you want to create the best environment for the mom. You don't want mom to have multi-organ system failure because that doesn't bode well for the unborn child. So deferoxamine has been used in pregnancy with good outcomes for both mother and child. You shouldn't hesitate to use it at all. Other supportive measures, fluid resuscitation, monitoring the perfusion, monitoring for signs of bleeding, bicarb is appropriate for acidosis, airway management is appropriate. And I would say the vast majority of these, even the ones that are not intubated and not in shock, need a Foley to monitor both the urine output to make sure the kidneys are being well perfused and the color change that we would expect to see if we're giving a chelator. So this is deferoxamine. Like aspirin, this is one of the things that causes bezoars. They're big lumps of especially sugar-coated tablets of iron. They can all stick together in the GI tract. Everything under the sun's been tried for these. I think Go Lightly is sort of the first move, try to wash it all out the other end. But people have even gone in if there's a big clump in the stomach with endoscopy and not so much retrieving them, but sort of breaking them up so they can be washed out the other end. There's also been case reports where they've just like have been sick and they've had to do a gastrotomy and essentially do a surgical procedure, open up the stomach or the intestine and scoop out all the undissolved pills and of the GI tract. And occasionally there's bowel perforations that need to be addressed surgically as well. So this is one of the ones where a surgeon may need to be involved in the sicker cases if certain things happen, like obstruction, perforation, or lots of pills still stuck in the stomach. How to not miss it in children, kids who come in with persistent anion gap acidosis. I think they had one of these over the weekend where some kid came in like multiple times and they couldn't figure out what was going on. It was like someone should check for lead and iron and things like that. Um, Bloody emesis, bloody diarrhea, unexplained shock, people who ingest vitamins look for iron poisoning. All right. Any questions? Go lightly as in improperly. Yes, it's go mostly or frequently or whatever. Why don't we take a 5-minute break? Get a little something to put my mouth here so I talk for hours straight. And we'll be back. It is 12:08, 2:08, sorry. I'll be back at 2:15, let's say, and I'll try to get through the other two. I may have to go over on one or the other, but hopefully you'll bear with me for those. And if you want to put the recording back on, we'll get started and talk about heavy metals. We're only going to talk about 3 metals today. There's a lot out there. I don't think they'll likely test you on the really exotic ones. We did mention barium in passing, so that's probably another one that potentially will show up. What's good reasons to test people for metals? We always get these calls. People got a metal panel that could include 20 different metals, and one of them is elevated. And what do you do about it? Getting a workup for vague symptoms, weakness, and dizziness probably is not a good reason. If someone has a specific hobby or occupation where they're working with metals and they think they've been exposed, and maybe a symptom complex that fits, and we'll talk about what those are, yes, I think they can get levels. People with chronic anemia, abdominal pain, I have a negative workup so far. I think certain levels like iron and lead may be worth working up. And then peripheral neuropathy with arsenic levels may be another reason. But there's lots of bad reasons, concerns that the water is contaminated with lead. It's just not enough water in drinking water to cause things. Concern about arsenic in apple juice and rice, concerns about dental filaments poisoning them with mercury, concerns about weakness, concerned about living in another place a long time ago where there was a mine or a smelter. And even the cobalt levels after hip replacement, in the absence of any symptoms, are probably not good to get because they may be in this in-between range that'll just get people upset. So what are the metals tests that we want to get? Serum levels, which are really whole blood levels, really the most important one is lead. Now, you can get a couple of whole blood levels of other ones, but the only one that I think we make decisions on is based on lead. Otherwise, urine levels are appropriate for both mercury and arsenic. And just avoid these comprehensive 20 metals panels because there's no reason to ever get all of those on any single person. So, lead comes up a lot recently with plumbism. Plumbing is also PB, the abbreviation for lead. Many of it from Roman times forward was made with lead pipes. We still have lead pipes in many, if not all, big cities around the country and many little and smaller cities as well. They will deteriorate slowly. There'll be lead in the water, but there probably isn't enough lead to cause problems. And in fact, it should be monitored at the source of the water and people notified when lead levels go up. The place where we really had problems with lead in this country was from paint. There was no surprise that paint was made of lead. There's an ad right in the top that says Dutch Boy white lead paint. It was right in the advertisement. The Dutch Boy painter, classic thing from the National Lead Company, had lead in it. It's no surprise when we scrape the paint off the wall or deteriorates naturally that paint is going to fall on the ground, and people who are crawling on the ground like little children will put their hands in their mouth and eat little bits of white lead paint. The good news is we've recognized this. We've passed a series of laws eliminating lead in paint in the early 1970s, eliminating it in gasoline, eliminating it in canning, and eliminating it in solder, eliminating it in a variety of other places. For now, our mean lead levels are below 2, where half a century ago, people had lead levels not too uncommonly in the 50s and 60s. That was more of a problem. Now, we haven't eliminated it at all, and it still happens periodically. And so we should be prepared to know how to deal with it. There's a lot of lead in our environment. It's in air pollution. It's in the air from exhaust. It's in deposited in soils. It's in pretty much every toy ever made is not made in the United States. It's painted in another country. Everything that's white and yellow has lead in it, pretty much. If you wanted to test it, it will. Paint chips, and then secondary exposure if someone works in an occupation like a smelter. We even had cases where dad worked in a firing range and got little bits of lead all over his pants and brought it home to his child. There are objects when eaten by children that we know are lead, and of course, we should watch them carefully until they pass it. And our recommendation has been to get at least one screening lead test on them somewhere, not immediately, after a few days that the lead's been in their body. Here's a list of them. I don't have to read them for you, but some of the most surprising ones are things like toy soldiers and pool chalk, if people eat those. Over the years, the amount of lead in general in children have been falling, and our reference level for what we call a problem has changed. And not too long ago, in the 1990s, 10 was the reference level or level of concern. It dropped down to 5 in 2012 and dropped down to 3.5 more recently in 2021. This is not a level above which the child is toxic. It's a reference level by which 95% of the children in the country likely will have levels lower than that. The flip side of that equation is 5% of the children in the country likely will have levels higher than that. That doesn't necessarily translate to being poisoned. So it often said there is no safe level, but there's also what's a reasonable level beyond which we can't really expect either clinical improvement or the level to fall further. It's often said that you can lose IQ points, even 3 to 5 points at every level below 10 for every one that it falls by. And that may be true, and there may be multiple cofactors associated with that, which often have to do with diet and poverty and access to healthcare. But while there's no safe level, I think there's a reasonable expectation that nowadays children should not be above 10, and clearly we should evaluate what their exposure is if it's above 3.5. For adults, it depends on the industry. Certain industries like painters of bridges and boats will tolerate higher levels. Metal workers and bridge workers can tolerate levels up to 40. These have been coming down, and in fact, there is a proposed rule bantering about to make an official recommendation to lower those adult lead levels back down to 10 as well. I don't know if it's going to happen, but I think that would excessively cause anxiety and worry in adults because there's a lot of people, especially older adults, who have been exposed to paint for their entire lives, who really have very little and any sort of end organ damage from it at those levels, but now are concerned that they were exposed, and what do I do about it? Lead in drinking water has occurred a lot, even before we got to Flint, Michigan. I just heard on the news yesterday that literally the entire city of Chicago has too much lead in the water. Someone just published something like this week on an AI model of lead in the water in Chicago, and it was like above the acceptable levels. So it's out there. There's a action level in water. I'm not going to go into too much of this. The lead and copper rule is by the EPA. It shouldn't be above 15 parts per million. That's sort of the short version of this. There's a whole bunch of rules about when you should take things offline and test them. But there actually isn't a mandate for any individual to test their own household water. That's sort of a up to you question. Lead in our diet and in the air is absorbed. It goes into the blood, and the blood partitions it out to soft tissue where it can be mobilized from, and bone, where it often can't be mobilized from except under severe stress and events. This is the pathophysiology. Some of these enzymes are excreted in the urine. Again, I don't think these show up on your tests, but protoporphyrin 9 is the one that accumulates in red blood cells that may be testable for, and delta aminolevinic acid is another one that can be tested for in the urine. Usually we just get lead, whole blood lead levels. So how high is too high? As far as who's likely to be sick, it's pretty unlikely for someone to have a actionable, noticeable, even testable with aggressive testing effect below 10. They may have decreased IQ points over time and decreased growth and hearing, but it really is very subtle. Around 20 or so, they may actually have decreased nerve conduction as well as problems with heme synthesis and vitamin synthesis. Usually about 40, which is sort of the occupational level, they will be anemic. They'll have decreased hemoglobin synthesis as well as increased vitamin D metabolism. Children may see colic at levels of 60 to 70. Death is often said to be around 140 to 150, although clearly we have had cases with levels that high who are not dead. They were maybe a little encephalopathic and they were treated and had good outcomes. This is sort of the classic chart on who needs treatment based on their blood lead concentration. We always like to use concentration in toxicology. In almost all the pediatric literature, it's a blood lead level. It's just one of those picayune complaints that we have between our specialties. If they're asymptomatic and the level's below 10, yeah, you should check them periodically, but they may have subtle signs that are probably not made better by chelation. Mild elevation between 10 and 40 or so, they may have some irritability, some fatigue, some learning disability. They should be investigated where the source is coming from, fill out a questionnaire about their diet, the paint, the age of their home, test the water in their pipes, check the paint, where they live, and if there's any foreign travel or foreign medicines or anything else used, those need to be checked for. Above 40, and some say 45, that's where we might see significant symptoms and may want to actually treat with the chelators that are available. Above 70, most people would recommend that they be hospitalized for that initial set of treatment. Many say above that level, they should have IV or IM chelators, although honestly, if they're only subtly impaired and able to take orally, oral chelators would work. There's a couple of things, I don't know if they'll ever show this, but occasionally we've made a diagnosis because an astute dentist found Burton's lead lines, these brownish discolorations at the teeth that isn't plaque, that is actually lead deposits. Another thing that sometimes we make the diagnosis with is a fragmentation of ribosomes, known as basophilic stippling, inside of the basophils. These little dots that you can see on some of these slides. Often that's just reported out in the lab slip. No one's actually looking at the slides of CBCs anymore themselves, but occasionally you'll see this finding. It'll say anemia with basophilic stippling. That child should have a lead level done, or the adult should have a lead level done, and figure out what's going on. Reproductive effects in men may have decreased sperm counts and motility. Women may have decreased ability to get pregnant. So these levels, even at lower than occupational levels, can be real. If a woman during pregnancy is elevated, especially in the chelatable elevated level, you need to anticipate and plan for testing the cord blood at birth of the child and chelating the child at birth as well. We've had issues where they didn't do it right away. They didn't send the test out stat, and it took 3 or 4 days before they actually started chelating the child. So how do we treat? The oral medication is called Sesamer or DMSA, which is the chemical abbreviation for it. Parenterally, the treatment is usually British anti-lewisite or BAL or dimercaprol. Those are all interchangeable equal names for BAL, followed by EDTA, an intravenous solution of chelators. Succimer is the most common thing we'll end up using, and we use this for the other metals we'll talk about here in a second. The first dose for 5 days is 3 times a day, and then drop down to twice a day for 14 days. This is the lead treatment thing we use, and we just borrow that same treatment level for other metals, although it doesn't make as much sense for other ones. Unfortunately, they do deplete vitamins, especially calcium and iron, and so after 14 days, or 19 days, I should say, between the two of these things, they need a 2-week hiatus where they get vitamins and iron and calcium. Then they can get another level drawn and get lead. If it's still above the treatable range, 35 to 45, they should get more of this. Now, the sulfhydryl groups, the sulfur groups, is what binds to metals. And this tablet is quite large. It's called Chemet there. 100 milligram tablet is typically how it comes. So if you have a child, what you have to do is open this capsule up and dump it in their pudding or their applesauce and feed it to them. And mom or dad has to be pretty compulsive for the first 5 days, 3 times a day, and then twice a day for the following 14 days of opening these capsules and feeding them applesauce laced with Succimer every day. The other option for severe cases is British anti-lewisite, which is almost gone in this country. They stopped making it. It's also called dimercaprol. It could show up on a test, but it's dissolved in peanut oil because it's a very poorly water-soluble agent. So if you're allergic to peanuts, especially people with really severe peanut allergies, they cannot have it. So that's potentially a testable reason. When can you not use BAL? It has to be given by a deep IM shot where the injection goes in and you have to kind of rub the tissue over the top of it so it doesn't leak out through the hole that's created by the tract. You can give it one of these shots Q4 hours intramuscularly. It's not available IV. Eventually, you run out of good muscle groups to inject this in after about a day or two. You can imagine 6 shots a day, 12 shots in 2 days. There's not that many muscle groups left to inject this stuff. Usually 2 days, people have gone up to a week for severe encephalopathy. It's got some side effects. It causes increased blood pressure, fever, rash, a sensation of compressed tightness in the chest and arms and jaws that are very uncomfortable. And they can have lots of ocular problems like lacrimation, blepharospasm of the muscles around the eyes, and conjunctivitis. So it's a not particularly well-tolerated drug, and those who have peanut allergies can't get it at all. And add to it the fact that almost nobody is making it or making it available anymore. We've practically stopped using it. It still could show up on the test. After at least 2 shots of that to try to bind up the lead, then you can start a constant infusion of calcium disodium EDTA. The doses will not be tested. Those are all look-upable. These also have sulfur groups on them that bind to the metals. You have to maintain good hydration with IV resuscitation, especially in the cephalopathic patient. Here's our case that we had here. Just to show you, this kid rolled in. He had eaten a lead medallion from a toy vending machine at a birthday party. And it took about a month before they figured out what was going on, and they didn't believe it, and they repeated it, and he had a level about 120, way above those critical lines. He actually got treated with Succimer, I believe, the entire time, and eventually took months before he got down to a level of 20 that was acceptable. Just leave this up there for Chuckles. Moving along to arsenic. This is the classic poison of the mystery books, arsenic and old lace, and people who are trying to like inheritors powder and things like that. It's in the paints of Paris green. People have speculated Napoleon was poisoned with this. So there's a rich history in literature and elsewhere for arsenic poisoning. But arsenic comes in 3 forms. It's not this uniform type of problem. There's elemental arsenic, which is the metal. There's organic arsenicals, which are large carbohydrates, which are generally not toxic. And then there's inorganic arsenical salts which are particularly toxic. So the inorganic salts, the arsenic trioxide, for instance, is particularly toxic. There's some other ones like sulfur salts and others that are out there. The organic arsenics, which is in seafood, mostly is arsenobentane, it's really not toxic. They've done studies where, like, if you go out and have a lobster dinner, your arsenic levels can go up above 1,000, but it's not the toxic arsenic variety. This is why when we get urine samples, we have to speciate the arsenic, and we care about the inorganic arsenic salts and not the organic food arsenic that occurs in seafood. As far as its toxicokinetics, it's absorbed pretty much every way. There have been people who have self-injected arsenic sometimes for reasons unknown. Half-life is cleared quickly in the plasma initially, but then for over weeks and months, there's a long distribution half-life that takes forever. It gets shunted into all the sort of soft tissues, the liver, kidneys, muscle, and even the skin. And the elimination in the urine is usually relatively complete in about a few weeks, peaks in a few days. It potentially crosses the placenta, potentially accumulates in the fetus, and potentially can occur in low levels in breast milk as well. Metabolism is complex and probably not worth remembering, other than you can have arsenate in the +5 that's converted to arsenate in the +3. This is kind of like iron we just talked about. And then it goes to monomethyl arsenic acid, which is one of the inorganic arsenics we can pick up. And it kind of gets shunted back and forth between these different forms. So what we recommend, because there's usually no acute arsenic poisoning, if we did suspect an acute arsenic poisoning, like someone ate an arsenic bottle, we might just get a spot urine just to prove it's there. But in general, most people think they're chronically poisoned with arsenic, so a 24-hour urine is appropriate for that. We want to have it speciated, which means show how much is organic versus inorganic, because again, we don't care about the organic arsenic. It's expected in anyone who's eaten seafood. The other option is to make sure they completely have a diet that's free of seafood, rice, kelp, and apples, things that have arsenic in them for a week, and then you can collect a 24-hour unspeciated urine specimen. But it's probably easier just to speciate the original specimen into organic and inorganic forms. If you have to eat, if someone eats arsenic, and we've had kids who've eaten these arsenic ant bait steaks, they usually get pretty sick pretty quickly. Within minutes, they have nausea, vomiting, and a cholera-like diarrhea, sort of a watery diarrhea that occurs as a result of arsenic that we mentioned with food poisoning last. They can get sinus tachycardia, but they're well known to produce long QT and torsades that can be delayed days to weeks after ingestion. So that's sort of a unique thing about that. And they tend to die of cerebral edema with microhemorrhages, which is usually symptomatic by a progressive encephalopathy, delirium, and coma and seizures. But every organ system in the body, the liver, the kidney, the lungs, can all be affected by arsenic. Chronically, it's rare. It's used in colored glass, as we found out with the bullseye glass debacle that happened here in this city. But very few of those people actually had true arsenic. They had exposure, but not arsenic poisoning. It tends to happen environmentally in other countries, like developing countries where wells were drilled through arsenical ores in Bangladesh, or people who live near smelters and mines where they harvest this. So after a lifetime of that exposure, you can have risk for malignancies. So it's a carcinogenic. Skin is the highest, but also lung, bladder, and liver. Perhaps there's an increased risk associated with diabetes, peripheral vascular disease, and lung disease. And then on their hands, they can get this hypopigmentation. One of the classic things they get is mesalines, which are interrupted growth plates in their nail beds. Not sure they would ever show you one of those, but that's what they look like. Here's a much more dramatic one where someone was poisoned over and over again, where each time they had inhibited growth of their nail bed. What they get on their hands are a variety of dermatitises. Again, it's not important to remember these. It's usually these brownish spots that happen that look like scabs, or what sometimes described as raindrops on a dusty road. These little hyperpigmented drops. So where do we see acute poisoning? Well, arsenic trioxide is used in ant bait, but it's also used to treat leukemia, acute promyelocytic leukemia. So in order to get a product like that on the market, of course, we have to know everything about its metabolism, and we do. It's an orphan drug. A dose is 10 milligrams IV for promyelocytic leukemia. You can get this daily for up to 60 days. That's a lot of arsenic. So you would think we would know exactly what happens to folks who get this. The truth is, the real risk is just a potential long QT syndrome, and it's supposed to be monitored for before and then during multiple frequencies during the treatment with arsenic for leukemia. The next metal I want to talk about is mercury, quicksilver. This is associated with the Danbury Shakes. This is where the Mad Hatter developed the madness part of it. The people who make hat and felt, who make it stiff by rubbing metal mercury over it, absorb that mercury over time and develop a subtle CNS altered mental status where they tend to be shy and delirious and have the Danbury and tremor, and that's the Mad Hatter. It's poorly absorbed by ingestion, so if you ate for some reason a thermometer and your GI tract was otherwise normal, it would not get absorbed and you would not have a substantial mercury level. And in fact, we don't test for it after people swallow mercury liquid or buy a thermometer. It's not well absorbed through the skin, but it can be vaporized and inhaled. And that's where we see most of it. People who are mining or hobbyist mining, trying to extract gold or silver, use mercury as the extraction method, inhale the heated mercury and get an acute pulmonary syndrome. Once it's absorbed that way, it could have a long half-life and they may need chelation for a while. We reported a case here with Matt Noble of someone who was doing artisanal gold mining and had a severe pulmonary injury, got intubated and needed days of pulmonary support and days of chelation with both BAL and EDTA, and eventually I think went home with Suxamer. So for all three of the metals, Suxamer works if they're not too sick to swallow, and BAL and EDTA work as well. Methyl mercury is sort of the chronic environmental one that we see, where it's in the food chain due to poor environmental containment, either leaking from plants or coming down in the rain. It kind of works its way up from the ground through the fish to us at the top of the food chain, and it can be positive and it can cross the placenta and have fetal malformations. This, of course, is the Namata Bay, Japan. The famous photos that were taken for the methyl mercury toxication from the factory that was in the bay. And this went on for 20, 30 years before it was finally stopped. They had hematologic abnormalities, neurotoxicity, memory loss, greatly constricted visual fields, which is sort of a unique thing, decreased hearing, and this teratogenicity of these severely spastic hands with contractures that were very disfiguring and crippling to the children who were born to mothers who were exposed to the water in Minamata Bay. As far as levels, there are blood and urine criteria, there are EPA levels for air and otherwise. But in general, when we check for mercury, it's levels above 100, we start getting concerned in the urine. Clearly above 200, you're probably likely to see some toxicity. People who have a random urine sample done and levels come in above the national average, which is very low, like 0.5 here, but they come in above that, but less than 200, they probably don't need it repeated. They probably don't need chelation. They're just somewhat exposed to mercury, which exists in our food stuff here and there. Some of it comes from amalgam, but not enough to be worthy of chelation. So any questions on that? Oh, I switched slides there. Yeah, the lead, yeah, it comes up over and over again, and we've responded to it with press releases from time to time. It's very difficult, risk communication, to tell people that just because your lead level is a little bit above the reference range doesn't necessarily mean that you're poisoned or need anything done. Let me finish up